All right, hello, welcome, good afternoon. Hi, everybody. As I'm sure you're all aware by now, I'm Bethany Bray. I'm the program chair of this year's conference. Thank you so much for joining us. I am a quantitative psychologist and very excited about this year's theme. Typically, you don't hear this often from the program chair, so it's really nice to be able to get to know everybody and see all of your smiling faces, and hopefully you're feeling inspired and excited to go back and work even harder at prevention science given our political state of affairs these days. This plenary is going to look slightly different than the ones that we've already seen, and a little bit more in line with the one that we'll have tomorrow. So I'm just going to take a couple of minutes and set the stage. I'm going to give a brief introduction both to the setup of this plenary and our speakers, and then we're going to have two amazing talks that will be a little bit longer than the ones that we've had earlier, and then I'm going to try to make you really excited to stay tomorrow morning and come to the ethics session, and Dr. Dorr is going to set the stage for us for that with her talk. So as we jump in this afternoon, what we want to do in our plenary is really leverage what we hope you found to be really inspiring and thought-provoking from the first two plenary sessions. So for those of you who maybe weren't able to attend, what we saw in the first session were three amazing speakers really talking about artificial intelligence, AI, and different ways that we can use that tool in different ways, different mechanisms, different models. We saw videos, we saw apps, to really start integrating that into our own work and to take that and import it into your own spaces. The plenary this morning, we took that one step further and kind of drilled down deeper into adaptive and tailored intervention programs and also implementation science, particularly Kate Guastaferro's talk at the end, speaking about decision-making in these contexts, particularly under limited resources defined in a variety of ways. But what we didn't talk about so far is you all are working in this amazing field, doing your own work. Many of us were not trained in these methods. We're not computer scientists. So you might be thinking to yourself, okay, this is great, but maybe some of us are still doing pen and paper surveys in particular contexts. Maybe we've moved into telehealth or phone surveys, or maybe we have taken the leap into app-based or web-based data collection. But even that is not quite far enough to get us into that AI space, and especially into intensive decision-making in things like ecological momentary assessment and highly adapted interventions. So what we put together today for our panel is hopefully taking that inspiration from the first two plenaries and really getting a little bit down and dirty in how you actually get started and how you actually do this work in your own space. So our speakers today are going to be talking about a variety of things. We're going to try to tie several threads together. One of the themes that I'd like you to take home is that as we've heard from our earlier speakers, this conceptualization and theoretical framing of how do you take your ideas that you might not know how to program yourself or even how to get started in AI and build those teams, how much time that takes once you build those teams, what are the questions you need to think about, and as you develop your own research program in this space, how to integrate these tools in a really equitable and ethical way that will take your research even farther. A second theme and thread that we'd like to pull together is one of the things that we really wanted to make sure was represented in this conference are, I'm obviously a quantitative methodologist, but qualitative work is equally, if not more important in this space. And so we really wanted to make sure that we highlighted tools like natural language processing and other tools like that. So our speakers will be tying all of these threads together so that when you go home, we want to see some papers in the next couple of years in prevention science about you integrating these approaches in your own work, and we are all here to help. Once we hear both of our talks and we let that germinate a little bit, our roundtable immediately after this is, of course, open for questions, just like any plenary session if we have a small group of really committed people. most of the questions in that session, we will, of course, be taking ethics-related questions, as we have at all of the roundtable discussions, but we also want to dig deeper into lessons learned and how we got started in this area and how you can too. And then, of course, tomorrow morning, our entire hour and 15-minute plenary that starts at 8:15 in this room is, no, sorry, 10:15 in this room, is all about ethics and ethics together with equity to make sure that we're really doing the best work that we can in this space. So as I've said several times over the course of this conference, what will happen is one speaker from each of the plenaries will join us on stage, and Brittany Cooper, our president, and myself are going to moderate a discussion based on the questions that you submit using this QR code. So what will happen is, first, each of our speakers are going to talk about 1 to 3 absolutely critical key ethical issues that they've had to wrestle with in their own work, and how you even get started in some of these challenges that might seem intractable at this point, and how to work through those issues with your colleagues. Once we talk briefly about all of those things, then the rest of the session is going to be open response, where Brittany and I will ask questions of the panel, and we'll just have a robust discussion. So really hoping, if you're staying through Friday, please come join us tomorrow morning. All right. Now, with that, I'm extremely pleased to introduce our speakers this morning. I'm going to do them one at a time, just as the other plenaries. So many of you have seen her around the conference and joined some roundtables, had some discussions with her already, but I'm very pleased to introduce you to Dr. Marina Tolou-Shams, who is the Kilroy Realty Professor of Psychiatry and Vice Chair of Community Engagement, Outreach and Advocacy in the Department of Psychiatry and Behavioral Sciences at the University of California, San Francisco. She's also Deputy Vice Chair for Research in that department and at the Zuckerberg San Francisco General Hospital. From 2015 to 2022, she served as director of UCSF's Division of Infant, Child, and Adolescent Psychiatry. And from 2006 to 2015, she served as director of the Rhode Island Family Court Mental Health Clinic, which she started as a cross-system collaboration between Brown Medical School and the RIFC. Dr. Tolou-Shams is trained as a pediatric and forensic psychologist and has many years of clinical experience with assessing and treating underserved adolescents and their families. She is focused broadly on developing and testing integrated mental health, substance use, sexual and reproductive health, prevention and treatment interventions at the individual, family, and systems levels. And she's going to have a bit of a focus on that systems level that we haven't heard quite as much about yet. Dr. Tolou-Shams currently directs the UCSF Juvenile Injustice Behavior Lab and is PI of several active NIH-funded trials aimed toward improving behavioral services access and outcomes and reducing health disparities for these youth. Specific emphasis includes gender and trauma responsive interventions for girls in the juvenile legal system, studying the impact of structural racism and discrimination on behavioral health outcomes and services utilization, and identifying ways to leverage technology to improve access to behavioral health care for systems-involved youth and families. So you could probably see the direction her talk is going to go in terms of justice. Join me in welcoming Dr. Tolou-Shams.
Hi, everyone. Thanks for coming in after lunch. Appreciate it. I saw the sun came out in Seattle, so really appreciate you being here. I am really excited to talk with you today, and hopefully more after. The roundtables have been really amazing. I think an opportunity to think about collaborations and really generative conversations. Today I'm going to talk about what we're calling precision justice and harnessing AI and digital health to expand behavioral health care access for systems-impacted youth. I have no disclosures or conflicts of interest to report, and before I start any of this whole body of work is a we body of work. It is a team body of work, and I just want to acknowledge all the multiple partners, the youth and young adults who share their time and experience. I want to acknowledge our funders, National Institute of Health, National Institute of Drug Abuse, National Institute of Mental Health, and various other funding sources that have really helped to foster this work moving forward. And at the end, you'll see something about my high school English teacher, so if you want to talk to me about that after, happy to share, because that was a long time ago. Okay, so this is our team, and we like to work hard and we like to play hard, and it's an amazing team of folks who are really committed to being change makers in the behavioral healthcare space for these young people and their families. So here's a little bit of a roadmap for today. So I'll just give you a bit of a spoiler alert. This is a scientific tale of innovation, struggle, and learning, not perfection. And so it's funny that I say not perfection, and then I go into talking about precision justice, right? But I'm going to talk about what that term means, and kind of how we're using it and thinking about this. And then I'm going to talk briefly about systems impacted youth needs in the mental health and substance use prevention and treatment space. I'm going to talk quite a bit about the cascade of care and what that is and why that's important to think about as we develop these interventions at the systems level to expand access to substance use prevention and treatment services, and talk then about forward direction for AI and prevention services access in the public sector in particular. So I asked our UCSF version of ChatGPT, give me definitions of precision medicine. What does that look like? And what you can see is that there are multiple definitions, each with their own kind of little bit of tailoring. And what I did was I put words in red that talk about individual tailoring, personalization, patient-specific across the 5 definitions that it gave me, as well as then in blue, really talking about the types of data that these precision medicine studies use, right? So National Institute of Health Versa says it's an approach to patient care that allows for more personalized treatment plans based on the individual characteristics of each patient, including their genetic makeup, lifestyle, and environment, for example. And so for those of you who may, I don't know if you're aware or not, but in 2019, August and Gerwitz, I hope I'm pronouncing that last name correctly, actually had a special issue in prevention science where they talked about moving towards a precision-based personalized framework for prevention science. And in that introduction that they wrote and throughout the special issue, they actually talk about individual level personalized prevention, that's a mouthful, personalized prevention at the individual level. So the what, right? So which risk factors to target, the why, the biological and psychosocial mechanisms that underlie those risk factors, and then the how, so the change strategies, right, that can be offered to modify those mechanisms and the delivery procedures, right, that enhance the accessibility and acceptability of these strategies for individuals. But they also talk actually about groups and community level intervention, and I added the systems piece because that's another group, community level intervention. But they talk about how personalized prevention can be used to modify prevention delivery systems, to institute targeted policy, and via macro environmental or structural changes, right, that vary across community or system. So all of this has led to us thinking about the work that we do in this space with youth in contact with the legal system and or child welfare systems as precision justice. So that being bringing aspects of precision medicine to tailoring, optimizing, which you heard a lot about this morning, and expanding access to mental health and substance use prevention services for youth in contact with the legal and our child welfare systems. And if we look at these areas of precision medicine that have already gone forth really in the broader healthcare system, we see studies with genetic and biomarker studies, we see personalized interventions, digital health tools being developed right in the space, data-driven decision-making, and collaborative models. And by that I mean collaborative across the youth, the patient, the individual, as well as the researchers and all those who are involved in identifying what is needed in this work. So these are some of the ways in which precision medicine is being applied, but very rarely, if at all, with youth in the legal system, in contact with the legal system, or with foster youth. And that's the work that we're really focused on. And we would argue that this need is across multiple ecological levels. systems impacted youth, families, and communities, and the public systems that are in contact with them. These youth don't live in a vacuum, as you all know, and they have multiple concentric circles around them. So this question of what are we, in air quotes, asking precision justice to actually address, and the we is in quotes because this we see as really critical to doing this work thoroughly and effectively. And our approach to answering the we is multifaceted. So our approach is actually to go to the community and ask them who the we should be, and are you the we, and what is the problem that you're trying to address. And we bring a social justice lens to the forefront, and we are talking with our partners about advancing behavioral health equity. Our space is behavioral health. And I just want to say something too. I'm saying behavioral health for a very specific reason, because in the juvenile legal system and the child welfare system, there's actually a lot of work to be done to disentangle what is mental health intervention versus substance use intervention. When these young people get referred for services, for example, they largely get referred to counseling. They largely get referred to mental health, substance use. We're not really sure what it is. So I'm putting it into that behavioral health bucket to acknowledge that that's the real world kind of situation that we're in, and we know that we have a dearth, particularly of substance use treatment services and substance use prevention services to refer these young people to. We also, there's a very specific framework around anti-racism in research that we bring to the table as well. And we bring all of those approaches to our community partners to identify and define the we and the problems that they're hoping to address. And as I was mentioning before, our work focuses largely on using eco-developmental theory, acknowledging that the individual lives in these concentric circles, family, extrafamilial, and then structural level influences, and that we want to start to think about how to develop multi-level interventions using these various approaches that I just outlined. So where does technology come in? The Venn diagram across all of these is something that I did not term. It's called tequity. And so what is tequity? So tequity is, according to the Tequity for Health Coalition, the intentional design and deployment of technology both to advance health equity and avoid deepening existing systemic inequities and health disparities. It includes technology as well as data practices. And here are some of the components to it, right? So trust, we've heard some of these components already throughout this conference. Who has access to the health tech? And who is initially using or adopting the health, health technology? So these can be, you know, through intentional design and integration of these features, which enhance user friendliness, you're actually opening up not only just access, but also adoption. For example, we haven't heard a lot yet in this conference, or at least I haven't. I'm sure there were some smaller sessions around these technologies being available in other languages, for example, outside of English. And what about for people with disabilities, right? So there are some ways that we really need to be thinking about how we make this more accessible and then adopted and sustained for long-term engagement. And then Clark brought to this tequity term the approaches of social justice and anti-racism, and said, you know, we really need to invest in people and communities. We have to be trustworthy and collect data that are relevant to diverse communities and keep it secure. These are some of the ethical issues that I'm sure are going to be discussed tomorrow. Develop innovative partnerships, and that the purchasers or users of tech must also drive the change, and that we must use AI and analytics to promote health equity, but huge caution, right? That I think many of you are going to talk about tomorrow. And this was borrowed, the challenges and threats of AI in mental health care was borrowed from Dr. Wright, from the American Psychological Association, and really talks very thoughtfully about how biased input leads to biased output. There's a need to protect sensitive data. There's a lack of transparency. pitch perfect accuracy. AI is like a black box. It's a black box to me. It's definitely going to, be a black box to our communities. So these are some of the things we need to think about. And Ruha Benjamin is an outstanding scholar who has published in this area, particularly as it relates to race and criminal justice and technology and the use of AI in that space. And Sasha Costanza-Chalk, for those of you who don't know, wrote a very interesting book about how we do lead with the community leads the practices that actually design the technology that we need. So from a methods perspective, we actually use something called participatory informatics. This was developed by Armin Aravian at UCLA, who has now branched off from UCLA and owns Chorus Technologies, which is the platform that we use to co-design our technologies with young people. And it's a blend of community participatory partnered research plus user-centered design. It needs to address the digital divide. Now here I'm not talking about the digital divide like we often hear about it related to access. It's really moving more in the direction now of like who's actually benefiting in terms of equity, right? And I think that's really where we need to go, because a lot of the studies are showing, even with our really severely impaired psychiatric populations, they actually do have phone access. But are the interventions, are the services that are available actually benefiting them as much as they are with someone without that severe mental health need? And then who creates matters. So you're going to hear me repeat this over and over again. I'm not going to say I'll get off that soapbox, because I won't. I'm going to stick on the soapbox. Here's a smattering of our current projects in the Juvenile and Justice Behavioral Health Lab, and I would be happy to talk about any of them. Foster space, I can't do it all today in this time, but in the roundtable or beyond. Foster Space is our behavioral health services app designed by and for youth in the foster care system, and we have a large-scale implementation science trial now to actually see how we can increase uptake of the Foster Space app with court-appointed special advocates who are volunteers working with foster youth in the state of California. Foster Care Family Mental Health Navigator, you're going to hear a little bit about. Family Telehealth Project is a family-based telehealth intervention for youth who are like across the state placed out of home to foster reunification between the youth and the caregiver of origin. Text 2 you're going to hear about, and then ECHO is a workforce development project, and then the Youth Justice and Family Wellbeing Technology Collaborative is a systems level collaborative that's acting like a think tank for across juvenile legal, child welfare, Department of Public Health, San Francisco Unified School District, and as acting as a think tank to seed these projects that they think, this question of like, what problem do we need to address? So we're just going to focus on these two today. And why are we focusing on this topic for youth in the legal system and foster care? Because there are a lot of data to suggest that these young people, for various reasons that I won't get into detail today, but have significantly higher rates of substance use and mental health treatment needs than youth who are not in contact with the system. Even those who are in first time ever contact reach the system, half of them have already used cannabis at age 14 and a half years, and past 4 months youth is 75% of those who are using. So we see really high rates. Now, this is more around secondary prevention that I'm talking about, right? So these may not be youth who have developed problematic substance use, but who have used and are in need of secondary prevention. We found that a year out later from those youth who hadn't used at first-time contact, close to 20% initiated contact within a year later. So we have a huge opportunity for prevention there. Families often go unsupported in these systems, very unfortunately, and we have significant gaps in access and continuity of care. So speaking of gaps in access and continuity, this is the cascade of care, the behavioral health cascade of care from the JJ trial study, which stands for Translational Research for Adolescents in the Legal System. And what JJ Trials was it was a multi-site national collaborative funded by National Institute on Drug Abuse. And they took the HIV prevention cascade of care, prevention and treatment cascade of care, looking at rates of screening, assessment, referral to treatment, and adapted it for young people who are community supervised, so not incarcerated, on probation, in diversion programs, to look and see how well are the justice system and the behavioral health providers collaborating to link young people who get screened in the justice system for mental health and substance use related needs. How well are they actually getting to services? So this is a hypothetical model going from screening all the way to continuing care, and you can see that the rates of those, they were hypothesizing the rates of those who actually get to treatment are going to be much lower than those who are in need. And what they did was, with 33 agencies across 7 US states, they did a chart review. They had 31,000 youth records. Pretty impressive work. They are an amazing group. And here's what they actually found. Huge cliffs at certain points of the cascade, one being from in need to referred. So we go from 58%, if you look at the imputed chart review data, 58% to 27%. And then again, you see another cliff from those who initiated treatment to actually engaging in treatment, from 30% to 7%. So we had funding from NIMH to actually look at this in terms of youth in the foster care system who are getting referred for in this foster care mental health clinic. And in California, there's actually a legal requirement for every young person coming through the child welfare system to get a mental health screening. And so this was our hypothetical cascade of care. And so the first thing I will say is, if you're going to be doing this work, you must co-design the cascade of care with those systems partners so that it fits their framework. You can't just take the JJ trial one and lob it on to your system. So this was what we developed. And here's what we found. Now, we did a one-site chart review of 97 youth. And what you can see here, too, is the cascade of care looks very similar. And we see this cliff again. So from 82.5% in need, going down to 55.7% referred. And here we get down to 16.5% who received any services. So if you go from 83% in need who actually get services, you go from 83% to 17% of kids. We have a lot of work to do in this space. So at the individual and family level, can we leverage technology to reduce these gaps with foster youth? So this was the results of our foster care family navigator intervention. And I'm not presenting all the methods because I don't have time in this talk, but I want to give you the take-home message, which is that this is a pilot study. All this work is very nascent. We enrolled 26 youth who also had electronic medical record data where we could actually assess this cascade of care using chart review data. They were randomized to receive either our foster care family navigator intervention, which was 6 human navigator interventions delivered by staff within the clinic. So there was an implementation science component to this. They delivered this 6-session intervention using PowerPoint over 3 months. This was co-designed with the staff and open trialed with youth and families to get feedback. They got those for 3 months, and then they had 3 months of care coordination. And they also had access to a Fostering Connections app, which was really just an app to communicate back and forth with their navigator. The control was just standard of care, case management. And what we see here is preliminary signal of effect that we actually can improve at each step of the cascade of care relative to those getting standard of care. And so thinking about the next steps for this was a hybrid. There was a lot of talk this morning also about human/technology interventions in terms of maximizing or optimizing outcomes. I'm just going to use that word all day because I like that word. But this is not an optimization trial, part of it. So this is a really nice initial signal that we should be thinking about how to move forward with this. At the individual youth and family level now, can we leverage technology to reduce the services engagement gap? So you remember I showed you that other gap, right? And this time for youth in contact with the legal system. So Project Text 2 might be the project that has kept me up most at night. I went into this work with the initial text project, which is cited down below, which was actually working directly with youth and families to determine feasibility and acceptability of delivering text messages to the youth and the caregiver on probation who are referred to substance use services in the community to see if it would enhance treatment attendance, and engagement. They loved the idea. Completely feasible, acceptable. Staff, probation staff did too. When we got to the next phase of actually doing a pilot trial where probation, youth, and caregivers received those text messages to increase substance use services engagement, and they were randomized to either receive those dyadic motivational messages plus appointment reminders or just appointment reminders. So that was the active versus the control. We learned a lot. I never thought that a text messaging intervention that I thought was going to be a very low-cost, accessible method, youth and families said, yes, sounds great, would be so, so challenging. The actual intervention was delivered over 90 days. We used a homegrown healthy SMS platform. Adrian Aguilera developed it with a tech developer. And both conditions received Monday, Friday appointment messages. Like on Monday, they got, are you planning to go to your appointments this week? On Friday, were you able to make it to your appointments this week? We had to do self-report, which I'll explain why later, why we couldn't use collateral data. There were multiple challenges in this. In the active condition, they also received Monday, Wednesday, Friday motivational messages based on the health belief model, and I'll show you some examples of those. The youth and the caregiver also received weekly tips. So the active condition and the control condition were both youth caregiver. It was dyadic. They had to both enroll. But control was just getting appointment reminders. So here's our health belief model-driven text messages. Youth and families in the first phase really helped us create these. We used a lot of visuals. They really wanted Canva visuals, for example. They wanted videos. They wanted YouTube videos, all of that. So they give really good input. And we found out that they actually wanted psychoeducation and stigma reduction messages too, plus appointment reminders. So we actually added psychoeducation messages, which we were like, oh, we missed that completely. Like they just want some knowledge, some psychoeducation, and stigma reduction, which was an initial part of the model. And these are some examples. Like your child is so much more than their diagnosis. We would send these little quick, snippets via text. Remember, dealing with tough situations is a skill. It can help your child to talk with someone they trust to get through it. And then we'd send them like a text-to project message of the day. These are examples for the youth, like psychoeducation. We tried to engage them by saying, you're spending your money on the wrong thing. You should spend it in investing in your future. Perceived barriers, and again, little message of the day around stigma reduction for young people. So they got those little Beyond videos for any of you who have used those. They're really great. Okay, so the challenges. Referral rates were less than 5% in our partnering county. So I thought it was bad when I saw JJ Trials and it was 15%. They were less than 5%. So we know there are challenges there. And we ended up partnering with 2 other sites, actually out of state. Referral rates were still extremely low, and we couldn't access collateral treatment data once we stepped out of state. It was just too hard to get those attendance data for services. We expanded to a national online sampling frame, so it's all self-referral, and we had to measure only self-reported attendance, but we said, look, this is a start. Let's do that. And we ended up with excessive numbers ineligible, and a high rate of increased scammers. Happy to talk about the scammers. That also was a new thing. So summary of our pilot trial results. I want you to see the dates up there, how long this took. 10/22 to October 25. And I thought we were in for like low burden, easy text messaging. I mean, I've done much harder like in-person behavioral interventions. So that was a surprise to me. 392 were screened, only 74 were eligible, and it was either like they weren't on probation or they weren't referred to substance use services or they weren't sure because they were just referred to a counselor and we couldn't verify if it was substance use related. So we had 25 dyads, so 50 participants, 25 youth caregiver dyads enrolled, 12 were randomized to the active condition, 13 to control. We found no differences in self-reported attendance, and we could say that, okay, well then reminders worked, just as well right? They both got reminders. Maybe that's why we don't have any differences in attendance. We also have many other issues to sort out, like do we have a ceiling effect? Like who actually ended up enrolling in this, right? 25 dyads, were they already going to be attending the treatment, the services? And also, you know, we started to like really think about whether or not we primed them through the self-report data. So if you remember, the Monday message said, do you have an appointment this week? Because that was the only way for us to collect it. And then we said, did you attend your appointment? So are we actually priming both conditions to attend? But maybe not a bad thing, because few juvenile legal or child welfare systems even use these reminders. These are absolutely everywhere in the healthcare system for appointment reminders, but we don't even use this kind of system. So even just that is a contribution that we could start to talk to our partners about. And so we see this as a lost opportunity for youth and family engagement too, like what you can kind of tag on to appointment reminders for systems that they want to maybe include. And what do we do about referrals? So I'm going back to some ways in which precision medicine is being applied. And we are thinking about how we use digital health tools, data-driven decision-making, and collaborative models to address this referral need. Because we can go at the engagement piece all we want, but if we don't fix this cliff from the in-need to referral, we are really going to be struggling. We're missing a huge swath of kids, and our state partner sees this too, our Office of Youth and Community Restoration that oversees all of they're like our Department of Juvenile Justice, but they're now in Health and Human Services. They're out of the carceral system. So I'm gonna end by talking just a couple minutes about text to JPO, Juvenile Probation Officer, which is a project that we are waiting for patiently. To answer this question of how might we use technology to increase rate of referrals for youth in need. And JJ Trials did actually do an intervention. It was an organizational change intervention. It was an amazing intervention where they had a core group and an enhanced group, and the core group, both conditions, actually both agencies got like staff training, they got supports in creating site feedback plans. The idea was to promote the care collaboration across behavioral health providers and the agencies that they were working with, the juvenile justice agencies or probation agencies. And they shifted the cascade a little bit in terms of referrals, somewhere between 3% to 7% increase in referrals for those that were in the enhanced condition, which provided also like an external support to those agencies, right? To be able to collaborate to enhance access and referrals. But the needle was small, you know, for a very labor-intensive intervention. So what they found, though, was that the barriers were that probation staff perceived referrals for substance use treatment as less important than multiple other things these young people were coping with. And there was less probation supervisor encouragement of referrals for those sites that didn't actually move the needle on referrals. And we have found in our qualitative work that probation staff and agency perceptions are that treatment is unavailable when it actually is available. So we're proposing to think now about nudge theory. And for those of you who may not know about nudge theory, it was brought up in some of our roundtables, but this is bringing in behavioral economics and cognitive psychology to think about ways that people's choices and behaviors can be influenced through small suggestions and positive reinforcement that are low cost. People in this kind of model can pursue any choice they wish. Nudges are not mandated for decision making, which is a huge paradigm shift for these systems that we're talking about. And they're often referred to as like choice architecture interventions. So these have been tested in the healthcare system with really, really amazing outcomes. So for example, putting messages into the EPIC system in the electronic medical record in hospitals for nurses, kind of, did you check in with your patient today about their vaccine schedule, right? Actually led to increased uptake of patient vaccines. And there have been other ways in which nudge theory has been used in the healthcare system, but it's never been applied to the juvenile legal or child welfare systems in this way. And so, my timer went off. Okay. Okay, perfect. Sorry about that. My timer went off, and I want to be respectful to our next speaker. So here is an example of a model that you can use to think about designing a nudge practice if you're thinking about this kind of systems, structural level intervention. My learning curve with this has been like this. And when I start to talk about the technology applied to this and thinking about it from a services and prevention perspective, there are lots of different intersections to be thinking about. So this model has 3 different steps. And the idea is that we are going to be co-designing these nudge messages and actual implementation of the nudges directly with juvenile probation officers and staff. Otherwise, it's not going to even leave the ground floor. The first thing is to identify the target behavior. The second is to identify what they call the friction and the fuel of the behavior. And the third is to design and implement the nudge. And so in this case, you go into a mapping process, behavioral process map. And this is just an example. So for example, screening for substance use is completed by juvenile probation department staff. Then a full substance use assessment is completed for those who meet the threshold of a need from the screening. The probation officer discusses with their supervisor about assessment results and the need for referral to treatment or other type of substance use services intervention. And then the probation officer staff search for match providers, provide detailed information to the youth and family regarding need for substance use intervention services. And then the probation officer communicates with the referring substance use services provider to provide relevant youth information to initiate this referral in the community and gives that information to the family. And then the youth makes the first appointment with the substance use services provider. Now that's the ideal behavioral process, right? But basically, you go through this behavioral process to learn about how each county is also going to be different. We're really clear on that in California and elsewhere in terms of their process. And you're going to identify the friction and the fuel of each step, each behavior in that behavioral process map. And then this framework talks about using the EAST messaging, which is making sure that nudges are easy, attractive, social, and timely. So I'm going to give you an example in our context. So step 1 that I was talking about is the JPO makes the substance use services referral. That's the target behavior, right? The question is, what is the target behavior? The second is, what's the friction and fuel that enables or prevents this behavior? And in this case, an example of friction would be that there are no regular probation officer and supervisor meetings in the workflow at all, right? That's going to slow things down, potentially based on the data from JJ trials in particular. The fuel could be that the probation and the substance use provider actually share the same electronic case management database for communication, which may be the case in some counties versus others. And an example of using the EAST framework for a nudge message could be if we say E2, which is like you use this framework to kind of come up with your different easy, attractive, social, timely. So if we say E2, which would be to reduce hassles, and S2, which would be the social network, an example of a nudge might be, have you met with your supervisor this week? Suggest a staff meeting to discuss referral challenges. Like we might suggest a staff meeting to discuss referral challenges, right? So we are talking about using text messaging for this to probation officers, but I want to be clear, like we might not end up with text messaging. It's got to be really driven by the system. It could be emails. It could be, I guess not phone calls anymore. I don't know what they're going to say about what they would think would actually fit in their workflow. That's actually a really big question. So the next steps are to partner with our Office of Youth Community and Restoration to, one, replicate actually JJ Trial survey across the counties to actually understand more quantitatively what's happening with them and their cascades of care, and also what their referral practices currently are on a broader level. and then to engage in participatory co-design and open trial with juvenile probation officers and supervisors to design these nudge messages. And then years 3 to 4, we're proposing a pilot efficacy trial with 100 JPOs, 50 per condition. But if you work in this space, we know that alternative designs are really what's most acceptable. So whether or not these counties are going to agree to a true RCT design is, again, to be determined. They said yes initially, but I'm not sure that they fully understand what they're going to be involved in co-designing, and then they may want the intervention right away. So I'll just say in closing, looking ahead for precision justice, and I'm so excited that Dr. Dorr is going to be following me because, looking ahead for precision justice, this is an amazing opportunity to think about how we use AI to improve referral triage, system decision support, and mental health and substance use prevention and treatment services matching in these systems. And really what's going to be key, I think, is the intersection of the use of AI for this implementation science, both from a quantitative and a qualitative perspective to really inform this work because it's so nascent. But I'm hoping that I'm leaving you with some ways of thinking about how you might apply some of these methods and how you might think about some of these within the systems and communities and groups that you are all working in to advance substance use prevention science. Thank you.
All right, as we get set up for our next speaker, I'm going to have the privilege of introducing her. All right, I'm very pleased to introduce Dr. Bonnie Dorr, who helped me conceptualize this session. Dr. Dorr is a professor in the Department of Computer and Information Science and Engineering at the University of Florida, where she directs the Natural Language Processing and Culture Laboratory. She is also an affiliate of the Florida Institute for National Security, former program manager of DARPA's Human Language Technology programs, and professor emerita at the University of Maryland. Dr. Dorr is a recognized leader in artificial intelligence and natural language, specializing in machine translation and cyber-aware language processing. Her research explores neural symbolic approaches for accuracy, robustness, and explainable outputs. Her applications include cyber event extraction for detecting and mitigating attacks, detecting influence campaigns, and building interpretable models. She is a NSF PCASE Fellow, a Sloan Fellow, and a Fellow of AAAI, ACL, and ACM. Please join me in welcoming Dr. Bonnie Dorr.
Thank you for that introduction, and it's just such a pleasure to be here. I'm a first-timer at SPR, so I am just really loving it here. What I'm going to be talking about, there was a great segue to this talk, thank you for that also, is that we are using natural language processing, I'll call it NLP, to detect early signs of mental health challenges in youth. And this work is part of an NIH-funded project called CyberSpill, led by Sarah Lynn, who's also speaking here at SPR, who's a moderator. And the project focuses on online behavior and experiences that impact adolescent mental health. So I'm going to dive right in, and we'll see how this goes. So the central theme of this talk is shown here: why prevention science urgently needs responsible NLP. It's a specialized branch of AI. And just for fun, here's an AI-generated image capturing that theme. The phrasing, as you can see here, responsibility NLP, is awkward, but that's kind of the point. It reflects how AI can be creative and flawed at the same time. So I kind of have a love-hate relationship with AI and LLMs, as you'll see throughout the talk. I've kept it here as a reminder of hallucination, a confident but incorrect AI output, which many of us may have experienced, and I'm going to return to that shortly. So here's a question that grounds the talk. What does it look like when AI supports prevention rather than replacing it? As an NLP researcher, I've spent my career teaching machines to understand language, but more recently, what I've been thinking about is a different question. What if those language tools could help us to understand emotional struggles earlier, especially in young people? Adolescents, as many of us know, share complex emotional realities online. They do this through Reddit or Discord or YouTube, and even in overlooked comment sections. So that's where the early signs of struggle are showing up today, and new signals can bring new responsibilities for prevention scientists. So my answer to this is that NLP can illuminate patterns, but it should never stand alone. Really important. This work has to be co-developed with prevention scientists defining priorities, clinicians guiding interpretation, NLP simply providing scale and support. And if done right, it's a team tool. It's not a shortcut. Collaboration ensures human-centered design. And I'm going to refer to this as principle number 1. We'll go through a few of these principles stated briefly. Support, don't replace clinical judgment through human-centered, co-designed AI. So, refining the prior question, can NLP help surface patterns of emotional distress in youth social media posts, just shown here? Social media offers new data streams that prevention science hasn't traditionally accessed, but they're rich with emotional signals. And our goal is to see whether natural language processing can detect mental health indicators from language. But early detection has to respect dignity and privacy. So these start to get into the areas of ethics that you said we would be getting to. So I'll get to some of that kind of starting halfway through the talk. So again, supporting but not replacing human experts, augmenting care, especially for youth who might otherwise go unseen. And so like the teen who wrote, "I feel invisible at school." Posts like that are often buried in the noise, but they're clues. Can we ethically and effectively bring those to light? So, I want to take a moment to consider what can go wrong and also what can go right with generative AI, which I'll abbreviate as Gen AI through this talk. And I'm going to focus on how to combine Gen AI with structured representations. A key risk in general is hallucinations. So this is a simple example, ChatGPT. From a year ago, I gave ChatGPT this blog conversation, and I asked, what's the attitude toward mandatory vaccinations in this dialogue, where Jan is saying there's no major study, but as soon as COVID-19 vax is available, they will immediately inject, question mark, crucially. Harry replies, no thanks, I'll take my chances. So I was actually surprised. ChatGPT, in a bad way, ChatGPT incorrectly interprets Jan as pro-vaccine, missing the skepticism in no major study, and misreading the question mark. It does correctly note that Harry is against the vaccine. So what's the moral of this story? Gen AI hallucinates because it's a language model. It is not a knowledge model. That's really important. It knows word patterns, but it can't infer the way humans infer. So that brings us to principle number 2. Don't assume that Gen AI outputs are correct. It may sound very confident, but still wrong. And that's dangerous in high-stakes areas like mental health, where fluency can be mistaken for understanding. So important lesson there. Brief digression. What is Gen AI? It doesn't seem to know stuff, but it can fool people. So we might want to know, what is it? So terms like Gen AI, LLMs, ChatGPT, they're often used interchangeably. They're not exactly the same thing. AI is the broad umbrella. LLMs, large language models, are one branch. ChatGPT is OpenAI's widely used implementation. And LLMs have actually been around for about 8 years. My students started working on them quite a while back, around 2016. They only recently gained attention through the media with ChatGPT, really since December 2022. It hasn't been that long. So how do these work? Well, Hugging Face offers a helpful review, but rather than sending you off to go read Hugging Face, I'll go through this, I'll give you the skinny. So it's actually a very simple model that has two parts. The first is pre-training from massive data sets, usually the whole World Wide Web, mostly written in English. So you were right that foreign language is one of my, I'm not going to talk about that in this talk, but foreign language is really a problem with large language models. So I talk about that in other talks, but won't have time for that today. All right, so that's pre-training. And so from that, for example, if the input is a dog is, it might predict a furry mammal. And from this, it predicts internal, or it builds out these internal representations of word relationships just by learning to guess the next word from the training data. So very simple, that's pre-training, builds a very general model. But the second part is not so general, it's the fine-tuning where the model learns to follow instructions and answer questions, which is essentially what ChatGPT does. And this is usually done through reinforcement learning from human feedback. So the model generates answers, humans rank them, and the model adjusts these based on those rankings. And the result is something called a preference model that helps the system choose among different answers. Often a different answer each time you ask the same question, which many of you may have experienced. So a dog is might yield a furry animal or man's best friend or fun to walk, could go on and on and on, right? So it's not always the same answer, and sometimes it's wrong. A lot of times it's wrong. What's surprising is that these models can now hold conversations, summarize documents, write code, translate, and much, much more. And it does it simply by combining training data, prompt input, and interaction context. Those are sort of the three key inputs to it. But here's where we run into trouble, something called the curse of recursion. That's when LLMs are trained on outputs from other models, especially flawed models, and this feedback loop can amplify spurious patterns and increase hallucination risk. And I've done some workshops on this problem called model implosion, where eventually, we might have been at a pristine state 1 or 2 years ago, but now there's a lot of synthesized data out there built by LLMs that it's now training on, and a lot of it's wrong. So a lot of hallucination, remediation, that's a lot of where effort is going to in many companies. 80 to 90% of the time is spent on hallucination remediation because of this. So the other thing is that a lot could go wrong with LLMs or Gen AI more broadly, and this image is from an article called Ethical Dilemmas of AI. It's cited at the bottom. It raises concerns from automated decision-making to self-driving cars to autonomous weapons to job displacement. But when Gen AI is used in sensitive areas like adolescent mental health, the risks become very personal and often more acute. For example, models might hallucinate high-risk interpretations like inferring suicidality or trauma when none exists, and these false positives can trigger unnecessary alarm and erode trust, both by clinicians and youth. And at the same time, there is a risk of missing actual distress, especially when teens use slang, sarcasm, memes, or indirect language. If the model can't read the nuance, those most in need could go unnoticed. And then there's the risk of over-reliance on the technology. So again, Gen AI can support but not replace human judgment. If clinicians defer too much to summaries or risk scores, we risk amplifying errors rather than preventing them. So that's something to worry about. And that brings us to several additional guiding principles for applying NLP in mental health. Some are tied to NLP design, like bringing hybrid symbolic LLM models together that make outputs clearer to clinicians and explainable. Others could be tied to data safeguards like de-identification, and still others are grounded in ethical responsibility, especially when working with vulnerable populations, vulnerable youth, and so on. Okay, so there's a lot that can go right with Gen AI. It brings enormous opportunities, from scaling solutions to staying globally competitive. But here's one area sort of near and dear to my heart: reducing hallucinations through representation. So my research explores, for example, how modeling hidden mental states like beliefs can improve both accuracy and explainability. For example, if we turn to that, I'm going to go back to that dialogue from 2 slides ago. The key insight is that Jan and possibly Harry they're sharing a hidden mental state, a belief that the vaccine is untested. So UF NLP researchers represent that as a propositional representation. Very simply, it's more complicated than this, but I'm trying to give the general idea here. The representation here is believe Jan and Harry, vax untested. So that's an abbreviation. So, but what's going on here is that if we bring these representations into generative AI, we could greatly improve reliability when errors, and more importantly, perhaps, when errors can happen, and they do, you can inspect the belief structure to trace where it went wrong. So that makes it more transparent, more explainable, because things just, they are going to go wrong. They are going to go awry. But what if we could figure out what happened and why, what went wrong here? So maybe it had an incorrect belief in the system. For example, thinking that Jan was pro-vaccine, maybe that there's some belief that it got wrong in the system. Perhaps more importantly, this approach can generate better outputs, like neither Jan nor Harry supports immediate vaccination, believing it will be taken too hastily without waiting for studies. Harry is even willing to take his chances without it. And there are 2 key points here. First, representing hidden mental states can support early detection of distress and enable timely intervention, but these structures also function as decision aids, highlighting signals, giving context, helping clinicians prioritize care. And that brings us to principle number 3, supporting clinical decision-making with interpretable NLP, using hybrid symbolic LLM models that reveal and explain, for example, in the context of mental health, hidden mental states. All right, this is just one example application area. There are others that we've worked in. By now, you must be wondering, what about data access and privacy? How do we ensure responsible NLP workflow and that we're supporting mental health clinicians? How does all this work? A more focused version of this question is, how do we embed ethical checks into the pipeline from the very start? So our aim is to co-develop research objectives and ensure privacy through de-identified data. Our workflow begins with IRB review before any data are touched. Data are drawn only from public sources like Reddit and are immediately de-identified with the originals permanently deleted. And our NLP models are designed to track aggregate trends. Very important here. We never target individuals. Even with de-identified data, this helps reduce the risk of surveillance and protects user privacy. And importantly, a human, usually a clinician, reviews the model's outputs to ensure they're clinically meaningful and ethically sound, which leads us to principle number 4, bake in ethics and privacy from the start through de-identification, aggregate level modeling, and human review. So our first priority has been to ground everything in these sorts of principles, the ones I've shared, and others I'm going to highlight as we go along with the remainder of the talk. And I'll go through an example where in the early stages of the cyber spill project, again, this is the one that Sarah Lynn is leading, and I'm one of the co-PIs. Our pilot study focuses on Asian American adolescents where family conflict emerges in posts from subreddits. For example, we're looking at the Asian Parent Stories subreddit, and we're applying emotion detection to de-identified posts from this community. The question is, why did we start here? NLP tools developed by my PhD student, Sungpil Yoon, reveal a high prevalence of family-related conflicting emotions in this group, and this signal can reflect deeper social stressors like family conflict or feelings of exclusion. This connection, I have to point out, is still under study. We have hypotheses that we're still testing very early. We just started this project this year, but the idea is So we propose that NLP can surface patterns that might otherwise be missed, offering new opportunities for insight and early intervention. So now, based on that motivation, the problem we're exploring is, does the co-occurrence of conflicting emotions relate to mental health impact? And a related study explores how emotion patterns correlate with depressive symptoms. Both lines of work really need to be tested for generalizability beyond the population we've studied thus far, but I'm kind of simplifying here and just showing what our preliminary study is. So for data and methods, we use 31,000 posts from Asian Parent Stories subreddit, and users here share emotionally complex experiences involving family, drawing empathy from peers, and each sentence is analyzed using an NLP model. It's called Go Emotions. I've given the citation on the slide here. And what does this do? It identifies 28 emotions across negative, ambiguous, and positive categories. Not everything is black and white, so it's not negative and positive. There's something in between. There is some gray area with respect to emotions or defining them. Okay. While I'm focusing here on emotion, Sungpil's dissertation extends this to sentiment, formality, and politeness, building on his earlier hallucination mitigation work, which I've cited here. By examining emotion, sentiment, formality, and politeness, these are related to mental health symptoms, or we're testing that hypothesis. What we're trying to do is gain insights into how adolescents' online language reflects well-being. For example, desire and disappointment may signal stress. I'll show a case on the next slide. And cyberspill depends on social media data to understand adolescent behavior through interaction patterns as well. Ultimately, our aim is to extract mental health indicators using NLP, and our success with emotion detection points toward a future integration of these other aspects like formality, politeness, and several others I'll show you in a minute as possible correlates for mental health. So we've recently gathered findings on the prevalence of conflicting emotions. And so this is, again, part of our preliminary pilot study. This heat map shows correlations between NLP-detected emotions per sentence. Mixed emotions are analyzed at the post level, our unit of analysis, using aggregated data to protect privacy, even beyond de-identification. And just so you know, I'm not sure you can read this, but that's okay. Blue blocks are negative correlations, red blocks, positive, lighter shades indicate a weaker relationship, and I'll point out a couple of these. Emotion labels are color-coded. Green is positive, purple is ambiguous, and blue is negative. So here are 3 examples of strongly correlated mixed emotions. The first one shows a Reddit post that NLP tools mark as approval, positive, and realization, which is really ambiguous. But I want to jump to this second case that I alluded to earlier, which NLP marks as desire, which is positive, and disappointment, both at the same time, which is negative. And you can see exactly what's going on here. So NLP is keying in on work up the courage, which indicates desire, and unfortunately, which indicates disappointment. And then there's a third case that I won't go through, but it has another mixed emotion of optimism, positive, and disapproval, negative. But you get the idea of how NLP operates on these Reddit posts from these types of examples. Sungpil and colleagues are now examining how these conflicting emotions may correlate with mental health indicators. Let's look at additional examples. This table shows representative NLP outputs. This is seriously hot off the press in that it's not publishable yet. These are you're getting a glimpse of something that will probably change next week. So I just want to warn you about that. But these are the types of outputs that we would get. For example, excuse me, can I ask? Let me see if I've got that right. Yeah. Reflects hesitation and neutral sentiment, probably low risk, but something like yeah, right, could express disapproval with negative sentiment. Maybe that suggests a moderate risk level. Again, all speculative for now. We have to test these, and we also have to bring in this whole community, prevention scientists and clinicians, to really take a look at this and validate some of these. Another one, everything feels heavy lately, which captures sadness and negative sentiment, possibly pointing toward higher risk. And those outputs, those three that I just showed you, are based on internal states like emotion, sentiment, mostly the left side of the table that you're seeing here. But this work in progress aims to extend beyond this, capturing externalized cues such as politeness and formality and tone, which is really the right side of the table. For example, please, I just want help, combines distress and politeness, that's the left side, or it's a combination, left side of the table and part of the right side, and that's a seemingly unlikely pairing, potentially signaling even higher risk. So that's sort of the goal here, is to test this hypothesis where extreme mismatch of emotions with other cues could signal higher risk. And there's a large space of combinations in this table that are largely unexplored. We have a lot more work to do, but ultimately AI predictions do have to incorporate internal and external signals, and more importantly, they have to be grounded in community-informed perspectives, not developed or designed or thought up by AI researchers, computer scientists, right? So we need this really is a team effort. Predicting risk, again, going from internal mental states, this includes emotion and sentiment. These are the core indicators of what someone might be feeling, whereas external cues like politeness and formality shape how people express what they feel. What does this matter? Like, why do we care about this? Because people may mask distress with polite or composed language. A post like, please, I just want help, may sound calm, but high politeness combined with distress could tell a different story, something we have to test. So we're building models to account for both layers, internal, the what, and external, how they say it, together giving a fuller picture of risk, potentially helping prevention scientists and clinicians notice signs that might otherwise be missed. But there's more beneath the surface here than what I've just talked about. And there's a part of this explored by another PhD student, Chathri Jayawira. Her approach opens up the black box, somebody mentioned black box, of Gen AI to show how reasoning happens. And this links directly to explainability, transparency, and a growing need to address hallucinations. So what about hallucinations? Well, shallow models often fail. They miss slang, cultural signals, implied intent, especially when ambiguity is deliberate, and that's risky in mental health where what's left unsaid often matters. We need an explainability layer, and that is what Chathri is focusing on. This is a mouthful: context-led elucidation and ambiguity resolution for natural language inference. That last part, NLI, I might say a few times. Natural language inference, that's the piece that she's added. So instead of ignoring ambiguity, it detects ambiguity, and rather than forcing a single right answer, it reveals multiple valid interpretations reflecting how humans reason when the meaning is unclear. It also explains each interpretation using common sense logic, helping users understand not just what the model says, but why. So we had what and how, and now moving into why. That's key to ethical and transparent AI. For example, the phrase, I'm fine, might signal genuine stability, or it could be emotional masking. It's context-driven. You can't just guess at it and pick one and act really confident about it. So this kind of explainability builds trust. It helps reduce hallucinations. It leaves room for human insight. And I want to just drill down briefly into an example. Clear NLI, that's Chathri's system, that she's still, it's again a work in progress, but anybody looking for a couple of postdocs next year, get in touch with me. I'd say a year and a half from now. So this explores how ambiguous language affects NLI with a focus on how humans interpret meaning in different ways. Ambiguity is especially risky, for mental health. You could misread a user's post. That could lead to serious misalignment or misjudgments of what's going on. So NLI just formally, is the task of deciding whether a hypothesis logically follows from a premise. The LLMs generally are going to, remember I told you they're real general, so they will default to a single interpretation, even when several are valid, and that can lead to overconfident or misleading inferences. So just taking this example, again, complicated diagram, but looking at the far left, the premise here in the it's a different color, purple, blue, whatever you want to call it, is I'm fine, I just don't want to talk about it. The hypothesis is the speaker is emotionally stable. Turns out, we don't know, right? So one interpretation, one interpretation at the top is the literal one. The hypothesis is entailed, right? So fine is literal. Whereas the second interpretation, the bottom one, so going all the way over to the far right, there's a potentially contradiction that fine is sarcastic or evasive. Maybe it suggests distress, contradicting the hypothesis. So both of these are held in parallel. There's no decision-making by an NLP machine here. So Clear NLI inserts that reasoning layer that I just spoke about. It draws on common sense knowledge, context, and tone to evaluate the options. It generates multiple disambiguated premise hypothesis pairs, each supported with contextual reasoning. It also blends symbolic and neural techniques. So LLMs entirely neural, but we need to imbue them with some sort of human-like reasoning, and that's what this is all about. And the result is multi-perspective analysis grounded in explainable propositional structures, like the belief representation that I showed you earlier in that conversation involving someone named Jan. And this makes it possible to detect distress when it's obscured by polite language, and this is just a citation to Chauthry's work. Okay, so everything I just mentioned raises a core question. What does it mean to infer mental health risk from language? Can I do this responsibly with AI? We have to worry about false positives, false negatives. Those are real risks in automated detection. This was talked about a lot yesterday morning. A post like, "You never understand me," could signal frustration, or maybe it's just venting. And that's why we never treat model outputs as facts. Everything's reviewed by humans. We're augmenting, not replacing clinicians. So this is not just about legal compliance, it's about honoring the human behind the post. And our IRB reviewed protocols require clinician involvement throughout. That's what brings us to this next principle, number 5. Model outputs are not facts. Clinical review is essential, and every post reflects a real human context not fully captured by algorithms. So as we push the boundaries of NLP in this arena, again, we've applied it to a bunch of areas, but mental health is the most recent one. We're asking, when does ethical monitoring become surveillance? In our work, we're defining monitoring as analyzing aggregate trends. For example, identifying emotion patterns across communities to surface early signs of risk. And this potentially helps prevention scientists understand broader shifts and trends without targeting individuals. And that's what that one is here. This is the contrast, surveillance. I think of this as real-time individual level tracking or interventions, sometimes without consent, and that's something we explicitly avoid. Our study focuses on public de-identified data. Our analysis remains at the community level. There's no usernames or profiling. Users are anonymous and untraceable. Given, so even our Go Emotions model that I spoke about in Sungpil's work has been fine-tuned only on public data with usernames replaced by anonymous IDs. It doesn't build profiles or track individuals, and that brings us to principle number 6, focus on community-level insights, never real-time flagging or individual intervention. Our goal is to support upstream prevention-focused science without compromising privacy, autonomy, or trust. So I'm nearing the end here, but we're touching on some of the things. We'll probably go into a lot tomorrow morning. Be there at 10:15? 10:15.
Yeah,
I'll just go through a couple of more slides, but they're quite relevant. So we're bringing AI into prevention science. Our work has to rest on a strong ethical foundation. I'll kind of summarize. First, privacy and consent, especially so participants, especially adolescents, deserve control over how their data is used, even when it's publicly available. Second, transparency. Our models, workflows, and intentions have to be visible to collaborators collaborators and communities, not hidden behind jargon or proprietary barriers. We have to minimize harm, and we do this through human oversight, contextual review, realistic framing of what our models can and can't do, something that often gets omitted in conversations about large language models, and responsible AI, explainable, testable paradigms for, in our situation, for mental health inference, models that can be trusted and validated, and finally, collaborative design. So we're working across disciplines. We rely on clinicians, prevention scientists, and AI researchers and data science to co-create tools that are context-aware, trustworthy, and practical for real-world use. Go over a few more challenges, because even with those ethical pillars in place, the path forward is filled with unresolved challenges. How do we balance early detection with the right to privacy, especially when signs of distress appear online, but are not, maybe they're not intended to be cries for help? Where does prevention and surveillance, prevention end and surveillance begin? So monitoring communities for trends, is that we see that as different as from targeting individuals, but again, eventually it comes to the individual. So how do you pull all this together? Clinicians can grow to trust AI too much, relying on outputs without understanding limitations. And finally, youth often use emotional or exaggerated language to connect with peers, and NLP has to respect that context instead of pathologizing every strong word or sarcastic post. So the call to action here is true collaboration, bringing prevention and AI researchers together as partners, not siloed. Design to support, not replace, human expertise, especially clinical judgment. Don't tack ethics on at the end. Ethical design is from the beginning, data collection, model training, and interpretation. This is not just about researchers. We need youth voices, community leaders, policymakers, and many, many others to shape the systems. And finally, we need to carry forward, I won't go over these are the principles that I mentioned throughout the talk. These guide how we build, deploy, and evaluate NLP for mental health. The bottom line is AI can't work in isolation. There has to be human oversight. Only together can we build systems that are ethical, effective, and trusted. Closing remark, if we get this right, I hope we can, I envision a future where responsible hybrid AI helps identify risks to support care, where models are co-designed with communities, trust is built in, where NLP tools can explain themselves, making it easier for clinicians to integrate them without giving up their own judgment, and most importantly, sustained partnerships across disciplines, institutes, and communities, because mental health isn't a technology problem, it's a human one, and the solution has to be human as well. All right, so thank you to the audience, to the SPR organizers. I actually think I see Sarah Lynn. Sorry, it took me a while to recognize. I can't see you all, but anyway, thank you. And all the collaborators listed here and many others that I haven't listed. And a shout out to DARPA and IARPA for supporting our AI research, in addition to NSF, which together helps us to bridge technology with mental health. Thank you.
So as we bring this session to a close, I double-checked. My sincere apologies. The ethics session starts at 10:45, not 10:15. 10:45 tomorrow morning, and we have about 5 minutes left, and I have one question I was hoping both of you could address briefly. In terms of our themes about getting started and lessons learned, for those of us in the audience who have been inspired during our conference and want to take further steps, or maybe even their first step into integrating things like this into their own work, do you have any advice about how to get started, or any resources, or how to reach out? How did you first bridge that gap with mental health, Bonnie in your case, and Marina in your case? How did you learn to take that first step from a basic text message into something that is sort of the next generation of juvenile justice?
There's many ways to get started. Shameless plug again. I have a couple of postdocs next year, though, not right now. Okay, so sorry? Postdoc opening? No, a couple of postdocs that you should have on your team. That's the shameless plug. But that's really part of the whole plan, right? That the expertise has to come from so many different areas, and building a team that has all those facets is really important. I happen to have 1.5 students who are passionate, and I'll say 1.5 because one of them is really split across areas, but very passionate about the sort of mental health arena, and but happens to be a computer scientist, AI, LLM, sort of strong linguistics background. So having all of that has really pushed forward. I think the Cyber Spill project, also thanks to Sarah Lynn, has made it, she reached out to me. She needed a computer science person. I brought in some expertise, and the team has sort of built itself out in a way that has made it easy for us to move into this space. Sungpil had some prior work as well. He had run some other studies using this type of technology, and now this project is helping him to generalize, because he has to defend his dissertation next year. So not just sticking to one particular population, but looking at the problem more generally. And one of the areas he's very key on, his passion, is in multilingual, bringing in that multilingual dimension. So he also brings that to the table, which I'm not sure is going to be used in Cyberspill, but it's another component of it. So my background has always been natural language processing, but also been very interdisciplinary over the years. My 3 degrees are in computer science, but I always had I minored in foreign language, and I minored in linguistics at MIT. So all of that brought together made me always want to reach out into these other areas. And I think that's, people, the application area, having experts in that application area, bringing them to the table, instead of deciding, well, I worked on this problem really hard, and I've got this hammer, and so this looks like a nail. Make sure that your results are validated, or your methodology unto itself, before you even begin. Make sure it's validated in that application area. And when it comes to Gen AI, make sure you're being really, really careful for the reasons I outlined in my talk.
So I would say a lot of humility. In academia, we might not do that so well. But where we're, doing this work in the community for 20 plus years in terms of thinking about how to increase access to care, really kind of builds that muscle for listening, right? And in the systems that you're listening. You may not even realize how much you're listening. And I really think it is about coming to the table. And I will say, in this space of reaching out to others, like you've been saying, to build these multidisciplinary teams. I mean, I was literally at the American Psychiatric Association with 2 amazing residents. Their MDs, their pre-life was like having a startup and Dropbox and, and all of these things. And I literally said to them, I am in these meetings, and I really feel like I don't know anything. Like, I feel like I'm just the person in the room who doesn't know anything. And that is like both very challenging, right, when you're at the later stages of your career as well, and an absolutely amazing thing, because what can come out of that are these ideas, because they actually don't know what you don't know. And so it's about being real and being in the space and saying, what was that? I don't understand that. What is that? Can you explain that to me? Like, I just learned so much from your talk, about NLP. Yeah.
LLMs are really stupid. So don't feel like, they're really, really that simple, what I just showed. Guess the next word. That's it.
But I guess what I'm saying is that there's an intimidation factor. I'm just going to, be straight. Like, I have been intimidated, and the way to reduce that intimidation is to be humble, step into the space, and have these conversations and be honest and real about, okay, this is what I can bring to the table. I need to learn from you. And that's what we do in community engaged work too, right? It's another way, but I didn't kind of realize that because I was in a different space. And then the other thing is I just really encourage you, and we need to stop, I know. So I'd really encourage you to look deep into your universities about what's available, because I'm at UCSF, I'm in the Bay Area, I'm in the bastion apparently, right? We just had OpenAI land there and open, but I really wasn't aware because I didn't know what I didn't know. So definitely scour, ask people, and network around it.
So it sounds like they're having a lot of fun outside. We can go join them right after. Let's thank our speakers again for such a wonderful session. Thank you for joining us.